to the first webinar in our series with the DigitalHealth.London here and the AI Centre. First workshop is what does robust governance of a learning healthcare system look like? So for those that don't know me, I'm Yasmin Stinchcombe. I'm the Senior Project Manager with DigitalHealth.London. Our panel will be discussing the unique governance challenge at each stage of machine learning cycle and what this means for achieving transformation at scale. Our panel is a range of experts from the NHS, academia, and from the AI Centre. We've got a fantastic panel of Robin Carpenter, Ethics Governance Lead for the AI Centre at King's College London. We've got George, who's also from the AI Centre. We've got Harris, who is the Head of Clinical Science, Commuting AI Centre from Guy's and St Thomas's. And we've also got Nicola, Byrne, who's the National Data Guardian for the National Data Guardian audience. Before we go into our panel, I'm going to hand over to the AI team, who's going to do a brief presentation just discussing what the fantastic work that the AI Centre has been doing. So if I hand over to you, Harris, fantastic.
It's actually George who's going to be taking this.
I'll start. Actually, do you mind starting with the next slide? It might be easier. So I'm Jorge Cardoso. I'm the CTO of the AI Centre. And our hope today is that we take you a little bit on the journey that we've been through in the past 3.5 years, building not only platforms, but also the governance models around using these platforms that are enable you to go all the way from your research question through your development process, all the way to deploying your algorithms clinically. And how do you take your researchers, your users on this journey in a way that is compliant with all the regulations and governance best practices out there? So the London Medical Imaging and AI Centre for Value-Based Healthcare is a consortium of 10 NHS trusts and 4 London universities. All of these London universities obviously are highly translational. And we've been working together also with external companies, including subcontracting companies that are doing part of the development, to build a platform that is common across all of these different hospitals. And many challenges come many challenges immediately appear when you're starting to implement these platforms. Things around how do you access data? How do you then make use of that data? What are the ethics around it? How do you make sure that we are adhering to all of the national data opt-outs, that we're only providing the data that is necessary and needed for different purposes? And then after you finish developing your algorithms, your analytics tools, your AI models, and you need to deploy them clinically, the next step is obviously how do you again do that in a way that adheres to all the governance and regulations and best practices throughout that journey. So if you could go to the next slide, please. There are 2 main platforms we've been working on. And on top of those, obviously, there is the governance and ethics model that we built. I'll be presenting the first one, which is the FLIP platform, which stands for Federated Learning and Interoperability Platform. The way you should think about FLIP is the research and development part of the life cycle. So it allows you to take data from your hospitals into an in-hospital data lake. So you are transforming the data from the standard data sources, including the EPR, patient notes, radiological images, and things like that. And you're basically bringing that data into an in-hospital data lake in a way that that data is made harmonized and interoperable. So every single one of our 10 hospitals will have one of these data lakes, and each one of these data lakes will contain the data from that trust. Because all these data is now made interoperable and harmonized inside of this data lake, you are then able to run algorithms and learn from that data at scale. The second question starts, how do you now learn across multiple hospitals, right? If every single one of these hospitals has this platform in place, and you want to be able to learn from data that is scattered around hospitals, the classic way of doing this would be to move the data into a centralized location. But obviously that's very contentious and will have a significant amount of governance issues, but also problems with ethics, anonymization, and etc. So the solution that we have come up with is to use something called federated learning, which is actually part of the title of the name of the platform. And the idea of federated learning is, rather than moving the data around, we're actually moving the algorithms around. We're doing something called distributed computing. So you can, if you think about an algorithm as a person, as a human that is going to an hospital to learn from data from that hospital, and then he goes to another hospital to learn from data from that second hospital, and he keeps moving between hospitals. The data itself doesn't need to move, but the algorithm, in this case, the knowledge that the algorithm is learning from this data, can be grasped and fetched from multiple sources without having that data moving around. And this creates obviously many benefits from the point of view of how the data, where the data is, who owns and controls the data, but also a lot of governance and control implications that comes with it. When you use both the federated learning platform or just a single site learning system, you then end up with an AI model, an algorithm that you've trained that is able to perform a task. And then the next stage of that is to be able to take that model and to deploy it clinically. And that's the second platform. And I will pass on to Harris to give us some insights on AID.
Fantastic. And so AID is a really crucial platform, not just when you have a machine learning or an AI application that's ready to impact care, but is actually able to have a much smoother transition from R&D into production, and is able to support AI applications that are much earlier in their readiness level and are potentially still under research investigations. What AID is fundamentally is a platform that can be installed in hospitals that allows you to integrate AI applications within a clinical workflow. And it does that primarily by speaking the language of healthcare and of hospitals. It has interfaces that uses standardized messaging formats and networking protocols to receive data from systems like PACS, which store radiological images, from radiology machines themselves, like ultrasound scanners or MRI scanners. It's able to ingest that information, pass it to an appropriate application. You can see sort of a list of them, hypothetical applications on the slide. And then once the analysis is complete, to then feed that back to the appropriate sync system. So that could be back to the PAC system for a radiologist to then report with the AI assistance, or it could be to the electronic health record or wherever it needs to go. And one of the fantastic things that's associated with AID itself is a NHS application store, which allows us to distribute algorithms across the partner hospitals that have AID installed. We're right in the middle of rolling this out across London and the Southeast. But that provides an interesting challenge when it comes to the governance of those models and their distribution and their subsequent use. A lot of these AI models would be considered medical devices, right? Because they're aiding in the diagnosis of a particular disease or management of treatment. And so it's really important that we don't simply, enable anyone to share and download these applications and have them run on live clinical data, but that we're surfacing the appropriate evaluation metrics so that people can make informed decisions, so that they can understand how these algorithms will perform on their patients and in their hospitals. It's also important to be very transparent around the limitations of these algorithms and in what use cases they can be performed. So if algorithms are at a very early stage, so they might not have had market approval, say from the MHRA, from a medical device perspective, then they should come with an associated research protocol and with a statement of use that restricts their application. And that's all enabled by the design of our application store. Or if they are approved for clinical use, it's very clear, which patients they're eligible for, right? So if an algorithm has only been evaluated on adult patients, then that should be made very clear as part of its distribution. We also have some pretty important features that help monitor applications once they've been deployed. One of the key aspects of that is our clinical review screen, which adds a human in the loop, allowing expert clinicians to review the outputs of AI algorithms before they're committed to the medical record. And that's a really powerful feature, not only to monitor the quality of those outputs before they then influence clinical decision making, but also as a mechanism to close a feedback loop back to the developer, right? So once we have these algorithms in the wild, we're not just letting them have an impact, we're also measuring their performance and feeding that back to the developer so that the next iteration is even better for our patients and for hospital operations. And now I'll pass the word to Robin to talk about a data access process.
Hi, everybody. So the first thing I would like to say is that your governance model when creating any platform will depend on the purpose at hand. So AI models will be at various stages, going from draft to market to deploy and then eventually decommission. And what stage that product is at will then define the requirements of the data access process. So this is a model that we developed across 2 years, originally for a centralized database of anonymized data for the early stages of training AI, and then it permeates depending on what it's being applied to. So it looks slightly different for Flip and it looks slightly different for AID. Actually changes in, there's 3 separate models for AID because of the 3 different purposes of AID. It's a bit of a governance beast. But all of the data access process will have the 3 same components, which you can see in the little blue box in the corner, which is contracts, compliance, and committees. And by that, I mean contracts which control what all the parties are committed to, making sure that it stays within regulation. And the next one being compliance, so making sure that it follows the regulation. Then committees, the people that oversee what's happening. So as you would expect, the different data access processes, the riskier the thing that you're trying to do is, the more scrutiny that you would find. And that's in line with regulation as well. So the medical device regulation obviously has various risk levels, and data protection legislation is a risk-based model as well. But the model that you can see on the screen, it requires projects to complete 3 forms. The first one is a project contract, which, as I said, will say what everyone's committing to. The next thing is a data protection impact assessment, which is where you evaluate the data protection risks and how you're going to mitigate them. And I'm happy that we get this in early on, because a mistake that organizations often make is that they use DPIAs to justify what they're doing instead of actually looking at the data protection risks, which could result of what you're trying to do. And then that's what third document is, a data flow document. So what data are you hoping to use, and where's it going to move, and how's it going to change as it goes through that process. So it gets drafted by the project team, and then it gets reviewed internally, usually by myself and by Harris. And once it's at a certain standard, to make sure it fits within our research ethics, because everything for this original model and most of the things that we do will be research on Flip, partly for AID, and always on this original platform that it was built for. After we ensure that it fits that and it fits the relevant regulation, then it goes to our data review committee, or data access committee, which is, so we have a lot of partners that we work with, and to me, the key partners are the NHS hospitals. So we have the data protection officers, or Caldecott Guardians, or senior members of government. Generally, it's the DPO and the Caldecott Guardian, who sits in on the committee to review the project. And there is also clinical scientists and researchers, because obviously to make sure there's a decent research rationale, and clinicians to make sure there's actual utility, because there's a huge issue across business in general, not just AI, where projects are done because they seem like good ideas but may not actually be that useful. So this is where we try and make sure that it's something that will be of use to the NHS. And most importantly on that committee is our members of the public, who I actually think are probably the most powerful people on the committee, as they should be. Then it passes through them. The project will get updates. So within the review by the AI Centre and by the Data Allocation Committee, there's usually a couple of like redraft cycles. Eventually it will go to the Centre Management Committee, which is like our board, who make sure that it fits strategically. And following those two approvals, a contract gets signed off by all the parties. And then this is where it would slightly change, because with the centralized database and anonymized data for that platform, the data would move. But for Flip, obviously, the data will not leave the hospitals, and for AIDS, the data won't leave the hospitals as well. And then the project can commence, and then you will move on to the stages that you would expect, i.e. Auditing, reporting back to the committees, and then eventually the end of the project, where you would write papers, you would delete data, you would archive data. Back to George, I think.
So, and actually, just to follow up on what Robin was saying, this is the current list of partners that we have. You can see that we have 4 universities, as I was saying before, involved, the 4 major London research universities with King's, Imperial, QMUL, and UCL, and also 11 trusts actually now, with the addition of Birmingham slightly further north. So we're not only even focusing around London and southeast of England, we're also trying to expand north in a very organic way. But I think what's important to see here is that both the platforms, but also the governance and ethics model that we have, were designed in a way that is appropriate for multiple types of users and researchers. You could be a startup, you could be a large multinational company, and you can be a university researcher or a hospital clinician. And we need to make sure that the systems that are created are actually appropriate for all of these different stakeholders, so that everyone can benefit from the infrastructure we built. So with this, I would just like to thank you all for listening to the talk, and we will now move to the rest of the session.
Fantastic. Thanks so much, George. I always find it fascinating hearing about all the work that the AI Centre is doing and kind of the different levels of development. So as we start our panel, I've got a couple of questions ready to go, but and I see some people have already started putting them in the chat. So I'm going to ask a few questions, but as we go, please put them in the chat and we'll open up to the audience shortly. So my first question, I'm going to direct to Robin. And you've kind of briefly alluded to this already, but in your opinion, which regulation should really be considered when you're starting to develop, and the life cycle of developing an AI tool?
Cool, thank you. So that's a big question, and I'm going to try not to delve too much into detail, because you could probably talk for an hour just on this one question alone. But if anyone wants to ask any more detailed questions, please throw them at me. But I think there are 4 main stages to developing AI, and those stages set the purpose, and then the purpose defines what regulation will be applied to it. And there's, fortunately, within healthcare research, there's a foundation, a long-standing foundation about how things should be done. So in research ethics, there's the Declaration of Helsinki, which led to good clinical practice. So anyone who works in clinical research will know there's certain things that you should be doing to make sure that your research is ethical, and we can lean on that when we're doing something new like AI research. Obviously, when you're using personal data, you would need to consider the data protection legislation, which also has a long history all the way back to Convention 108 in the 80s, and then the various data protection acts and the impact of the EU on that. And then there's also the medical device regulation, which is slightly newer and didn't arrive with such a bang, but it's still has been around for quite a long time. And then the final thing is the duty of confidentiality, which basically says that the data you share with your clinician won't be shared beyond the direct care team without something like your consent or some kind of mitigation, which people know as a CAC 251. So they're the main regulations that you would think about. And then there's also the recent mandate, which is the National Data Opt-out, which basically says, if you don't want your confidential patient information used for research or planning, then you can go to this NHS digital platform and opt out. And we also put a link to that on the AI Centre website, so people can choose not to have their data used for research. So that's like the high level main foundations across the board. And then if you're conducting research, you might want to speak to the Health Research Authority, who their remit is NHS data being used for research. So you'd go to them, and then your project and all your product documents would be reviewed by a research ethics committee. And it's something that, because this is so new, flipping age, that we've worked quite closely with HRA to work out how they would approve these projects appropriately. And it basically felt anyone who is in the HRA world, it fell pretty much down to a research database approval, but with some slight permutation, because obviously what we're describing isn't really a traditional research database. And then finally, you're going to want to think about any legislation that is relevant to your area. So if your AI, in theory, could have an impact on people being sectioned for psychiatric reasons, then you might want to look at the Mental Health Act, for example. So the developmental stage the development stage of the AI will set the purpose, and then that sets the regulation that you want to look at. And then you can build on top of that with best practice. So if you're looking at the later stages of AI development, you want to look at the NICE evidence standards framework to look at what kind of evidence a hospital might be asking for before procuring an AI product. But admittedly, different hospitals have different thresholds of evidence expectations, or if you're looking at a product, then you if the hospital's looking at a product, then they might also consider the NHS Act DTAC, which looks at how to check the product in itself that it fits what's expected. I'm going to keep it there, but people, please throw questions at me if you want more.
Fantastic. Thanks so much, Robin. And as I say, please add your questions in the chat as we go. There might be some answers that the team can kind of drop in. Kind of just following on from that, Nicola, what do you think are the potential challenges of using healthcare data in kind of where you've been looking at? And have you actually seen any examples where there's been good practice?
I'll probably just say a little bit about my role, just to put my answer into text, if that's okay. So as National Data Guardian for Health and Adult Social Care in England, my role is to advise, guide and challenge the government and the health and care system on the use of data, with a particular focus on a mission to preserve public trust in the confidentiality of our health and care system, so that both public and professional can be confident that when information is shared, that the privacy will be respected and it will only be used for purposes of public benefit. So I hope that sort of puts some of my answers into context. I think as a general question around challenges, perhaps the first one is the same for AI as for any data and digital development, I think, is the first is a strength of working relationships. And I think that's both within teams, within organizations, across organizations, and then with the public, because without strong functioning working relationships, we can't deliver any of this. So that would be my first sort of general data and digital point. But I think the second point, again, is general, but I think does pick up on some very important themes for work in AI that I think sort of touches on some of the things that Robin and Harris have already been talking about. But I think a challenge is that increasingly over the last few years, I think people recognize that trust and ask on the public. I think you need to demonstrate why your system is trustworthy. And I think there are sort of conditions that need to be met for that. And over the last year, I've been in role now just over a year. And the analogy that's come to me, I think that's been quite helpful for me, is thinking about it. I'm sure some of you will be familiar with Maslow's hierarchy of need in psychology, where we have these different levels of needs as human beings for our own maturity. They start the most basic, the food, the shelter, and they move up through sort of our cognitive maturation and development and emotional development. And I think for data ecosystems, there's a similar sort of parallel in that a lot of my conversations involve moving people on from what I see as a sort of bottom rung of a data ecosystem maturity, which is legal compliance. Of course, you can't be doing stuff that's illegal, but legal compliance in and of itself is a necessary but insufficient condition to demonstrate that you're trustworthy. Some of the things, the other layers on top of that very much speak to some of the things we've heard about. Privacy protection coming next, I'd say the importance of that. Meaningful transparency, so beyond sort of fulfilling your data protection regulation obligations for transparency, which might be fulfilled by simply putting an awful lot of stuff online that's there, but impossible for members of the public or even myself as a clinician to navigate and make sense of. So the question of what does meaningful transparency look like, especially when you're working in a field that's as new and complex as AI. And above that, I think, is a sort of demonstration of public benefit, and I could perhaps speak a little more about that later, but the importance of public benefit always having to sort of authentically engage with risk as well, and being sort of upfront and straight with people about that. On top of that, to choices, the importance of being clear with people what their choices are. And at the very top of my sort of hierarchy of need for ecosystem maturity is the question of power and how that's exercised. Who gets to make decisions and how? And I think Vin's brought some of that in for us already, and Harris too, because I think when we're thinking about AI, I think there are questions for how involved the public are in making decisions, but also thinking about the innate nature of the technology itself. We've heard a little bit about clinician override or clinician overview of output. To what degree are we building systems where clinician power, patient power, public power can be thought about in a sort of reflective, mature way? And I think that's really important. I'll leave it there as those two sort of headline challenges: relationships and that question of demonstrating trust.
Just following on from that, have you actually seen any kind of really good practices of data kind of within the system for system improvements?
Well, I mean, I'm not saying this purely, I'm not being paid to say this, or indeed because I've had a lovely cup of tea maybe this morning here on my arrival, but I do think I had some experience of sitting on the data access committee or the DAC committee. I'm not getting that acronym right, am I, Robin? When I was Caldecott Guardian and CCIO at SLAM.
Yeah.
And I felt, being in the room, that did feel like a very authentic engagement with clinicians and the public about what it is you're trying to do, and actually work through beyond, as I say, questions of legal compliance. You come back to, well, this may be legal to do, but that doesn't mean it's the right thing to do. And I don't think any one of us as individuals necessarily has the answers, myself included, as to what the right thing to do is, or what the right level of risk to tolerate is when it comes, for example, for privacy protection. So I think those are questions we can make if we make them together with a sort of diverse range of perspectives. So, I mean, my experience, I have to say, on that committee, although relatively short-lived, was a very positive one.
Fantastic. Great to hear kind of real experience and kind of where things are really going well and kind of really understanding the challenges. Harris, over to you.
Yeah, I just wanted to pick up on a point a broader point that Nicola was making, in that for building that trust and for that engagement to be authentic, there is partly sort of an education requirement or responsibility on our end. And speaking particularly from the aid perspective and thinking about the important role that frontline clinicians have in governance, right? In the role they have in, for example, being able to flag issues or risks that they're seeing with the use of AI on the front line. One of the things that, and this is also pointed to a question from Martin in the chat, that the aid allows you to do is it allows you to run algorithms that are sort of not really ready yet for showtime, and you can run them in research mode or in quality assurance mode, which effectively allows institutions and clinicians to become familiar and build that intuition of how algorithms are performing without introducing risk into the front line. And that's a really big important part of the puzzle here, is building confidence and experience amongst our frontline clinicians with using these technologies, because it's not enough to say there is a human in the loop. It's how have you developed that human, the clinician, what skills and experience do they have in order to do that role effectively. And so we've tried to build in that transitionary process into the platform itself, by having those safety controls beforehand.
So I'm going to open up my next question to kind of the wider panel, just thinking about kind of the public. In what ways can you get the public more involved with kind of developing the different tools, whether it's within research or practice, and kind of what can you do? Robin, if I open up to you first.
Yeah, please. So one of the best parts of my job is that I get to speak to our PPI members, and they really are amazing, because they listen and they think, but they also don't pull their punches, which is really important, because there's this kind of cultural change gradually in research where, sadly, patient and public involvement was originally just seen as this thing that you should be doing. And the way that it was done, often, not always, was that researchers would go to a PPI group and then say, I'm doing this thing, isn't that great? And then they would say, sure. And they'd be like, great, cool, the public's on board, let's do it. Which isn't meaningful. It's just a tick box. Whereas what we've really tried to develop, and we've developed some guidelines for researchers that are doing research with the AI Centre, is a way of cultivating a meaningful conversation. And that's quite difficult to do, because how would you measure meaning? It's not something that you can put numbers to. But we've created these guidelines around basically that you should find that your project's been changed in some kind of way. And that alludes to the first of the 3 ways that you can involve members of public in what you're doing. So you can, with every project you're doing, which is what we expect the AI Centre projects, is that they will involve members of the public and have some kind of feedback and relationship with them. And then the second way is that you can bake public involvement itself into the governance process. So in the early days of us looking at Flip and Aid, I spoke to our PPI members and said, this is something that we want to do. What do you think about it? And generally the reaction was positive, and when there are concerns, they're fed back. Just like one of our PPI members looked at our description of Flip and Aid on the website, and he said in a certain way, I don't know what the hell you're talking about, you need to change that, which is great. That's what you need to hear. So then we changed it, and we're going to change our website again soon as well, because it needs to be improved upon. So yeah, you can bake the second way, so you can bake public involvement into what you're doing. And then the third way is that you can address the really big questions with a Citizen Summit, which is something that I think the AI Centre is getting to the stage where we need to be thinking about that as these platforms grow. And there's lots of questions in AI healthcare, just because there's a real push from policy. So like there's the national AI strategy from the government, that basically they want the UK to be an AI superpower, and the pillars for that are obviously investment and education in the workforce they can use, and correct governance around that. But that then opens up a load of questions. Like I was speaking to a director of one of our partner trusts, and he was like, if we put AI into our hospital, and then it scans everyone's records for like the past 5 years, and then it finds that someone is at risk of something, do we have a duty to then go and find that person and then tell them? As in, I mean, they could have moved country, they could have died, they could have something else, they might not be very easy to find. And logically, yes. And if you look at other similar regulation, it makes sense that there's still that duty of care, but it's what has been written isn't set out for that now. So we need to have conversations with the public to work out what our direction should be, and that is happening, and loads of great places doing that, and the AI Centre is also pushing on doing that. But one thing I will say is that there is a well-known problem in PPI, that the majority of people you speak to are white, educated, retired people, and they still bring loads of value to it. Not to undermine everything that has come from that, and all the the real changes that have been brought about, but that's also one perspective. So one thing we're doing right now in the AI Centre is looking how you can better engage disengaged groups, and we've hired up a behavioural science consultant, and we're going to do some research. So that's what I'll say on that. But yeah, they're the 3 main paths: is Citizen Summit, baking it into the governance, and project specific.
Yeah, I think it's so important to really kind of, the key thing as well is when you're involving like patients or people as part of any of this, whether it's any type of healthcare, is really making sure the language is suitable and people really understand the concept. It's great to kind of hear all the different things that you're starting to do and kind of aiming to go forward. I'm going to ask George one question before I open up to the audience, just kind of thinking about data. So what sort of data should you really be focusing on when developing an AI tool, and kind of are there any specific challenges around that? So we talked about kind of access to data, but I'll hand over to you.
Yes, of course. So AI tools can be incredibly broad. They can really be applied to almost anything in the healthcare setting. Currently, what we're seeing in the market, and by market I mean startups and big international companies, is they've been focusing primarily on medical images, because that's where big revolutions in AI have happened in terms of performance and technology. But obviously, many other types of data can be used here. For example, being able to understand patient notes and discharge notes and the content of those, being able to act when you see, for example, results from a blood sample coming out, and being able to warn and highlight that the patient might be at risk or might have something that requires immediate action. But also there is an incredible amount of very interesting use cases that are not even patient-centric, but hospital-centric. So operational use cases where you are, for example, trying to predict if a patient is going to miss their appointments, or how many beds are you going to have available tomorrow in your hyperacute stroke unit. So operational questions like those also utilize data that is available currently in an hospital setting, but is often sitting in the background. And all of these different types of data have different risks associated with this. And obviously, there's always a duty of that the amount of data that is made available and that is used is proportional to the aims, and also related to the risks that are associated with learning from that data and deploying algorithms that are trained on that data. And all of these things are exactly the elements that that committees like the DAC discuss when they are planning to approve or reject certain applications. They need to be considered on a one-to-one basis. It's very complicated to make broad statements, but all of these things are taken into account when, for example, we provide access to specific data sets.
Fantastic. So over to my lovely audience. I've had some questions already coming through in the chat, so I'm just going to kind of start at the top. I know some of them have already kind of been answered. Robin, there's one for you. If a tech provider is allowed access to data, are there any restrictions to the computing we use, high performance computing, etc.? Can you say something about how a HPC system would connect with your platform? It might be that Harris would also.
Yeah, I mean, from a technical perspective, it's probably better to come from Harris or George, but I would say that we keep things pretty locked down. And if we ever did change anything, it would come under scrutiny of the hospital as the data controller, and obviously would require the things you would expect, like a DPIA, and to make sure that the changes are safe and data is moving in an appropriate way. But whether that would actually happen, probably not best for me to comment on that. I don't know if George or Harris has anything to say.
Yeah, I was just going to add a couple of points on this. So the platform we built has some very some intrinsic protections that go beyond just people respecting the governance processes themselves. So the platforms themselves lock you out of you being able to do things. Obviously, we're not saying that people have nefarious intent. Sometimes you might just access data that you don't have the rights to, right? And the platforms allow you to lock that data. For example, when you submit for a specific project, you submit a specific data query, and that is the one that gets approved. And that's the only query that you can run. But that query is also running on a live version of the data that is continuously updated. So for example, if a patient happens to opt out via the national opt-out system, that data is automatically removed from that data query. And from the point of view of the researcher, they don't see that happening. It's just that data point disappears from the next time that they run the algorithm. So all of these constraints mean that even if the users are non-compliant, or even if the users are not ill-intended but just make mistakes and are using data that they shouldn't be using, the platforms we built lock you out of that ability. So they give us the technical constraints that are needed. Obviously, a lot of other constraints beyond the technical ones are necessary, right? And that those are the things that Robin was talking about. There are processes in place to make sure that everything is done according to the rules, both in spirit and letter of the law. But also there are technical mechanisms to make sure that even if you make a mistake, you are not going to breach that.
Great, thank you so much. Next question is from Martin, and this is for Harris. So testing new tech for a service redesign using AI is quite disruptive for clinicians. Is AID designed to help test and modernize a modernized care pathway, and how can it be implemented before it's fully rolled out? Or is it a fully vetted algorithm? I know some of this has already been partially answered in the chat, but I don't know if you want to expand on anything.
Yeah, exactly. Yeah, I mentioned in a previous answer about sort of you can deploy algorithms in sort of different modes depending on how mature the algorithm is. But the bigger feature is that AID allows you to take an enterprise approach to deploying AI and transforming care pathways. And what that means then is that efforts should be made from an organizational perspective to tie the deployment of AI with traditional service redesign, service improvement processes that already exist in hospitals, right? So you will already have quality improvement teams, care redesign teams, and by having an enterprise system, one that isn't, a research endeavor, but is actually focused around business as usual processes, you then allow those things to come together. The challenge we had at the moment, or we had historically with the integration of AI into care redesign, is that it was very much trying to fit R&D activity and into what is potentially quite a disruptive process for clinicians, as Martin pointed out, and it's quite a big chasm to cross. By having this platform sitting in the hospital, a lot like a PAC system or an EPR system, it allows you to bridge that gap, right? And it builds a lot of familiarity with the hospital, so that you have a much smoother transition, and so it looks a lot less experimental.
Sorry. Got a question here from Lisa. So does each data lake at each centre need to get research data approval from the HRA?
Probably best if I take that. So we looked at whether each, so the data never leaves the trust for Flip and Aid. So the lakes are within each trust, and each trust has the same technical and software setup. And we looked at whether, because it remains at each trust and all the research is taking place there, whether each trust should have its own HRA and in HRA approval. And in theory, that could happen and could make sense. But in practice, when you try to overlap different HRA approvals, one detail can send the whole thing out. Because you eventually have one activity, and that activity obviously has to line up across through all those HRA applications. So if you then did try to do that, you would end up making each application so broad that it's meaningless. So the logical place to take that was to have one application which went across all the hospitals. And obviously, when we're creating applications, again, we have the data allocation committee, which brings a whole consortium of hospitals together, so we can discuss anything to make sure we have an agreed approach. And there have been a couple of really long conversations to make sure we're all in agreement of how we should do things. But that was our final decision, was one approval for the whole for each platform.
Thank you. Nicola, I've just found one in the chat from Hannah. I think when you were talking earlier, you mentioned a data set. So does the data set that you mentioned include genomic data or self-reported race data?
I wasn't mentioning any specific data set. I think whatever data you're using and for whatever purpose, and I think just as George said, the breadth of this, where we could focus here in terms of different applications, different types of data is vast. I think the things I was referencing more sort of high level ideas for whatever it is doing. Does that make sense? And that would include questions around genomic data use as well, or any other kind. I think, I'm not sure if the question's getting at questions of bias as well.
Can I maybe make a comment on this, if you don't mind, Nicola?
Yeah, so, please.
The reason behind of our, for example, federated learning platform was exactly for these kinds of incredibly contentious data use cases. For example, there are many ways that you can access data, and in many other research centers and universities and hospitals throughout England, you can easily pull data out and anonymize that data. But obviously, there's different types of data, such as genetics, that can never be made fully anonymous. And there's also other types of data, such as racial data, for example, that can be very contentious. Via mechanisms such as the federated learning system, the user, the researcher, the person developing the algorithm, does not actually see the data themselves. They can send the algorithm to the federated learning platform, which will learn from the data, but it will use the data, but the researcher does not actually see the data themselves. That massively minimizes the amounts of risk that might exist in terms of data re-identification, and also removes some contentious issues from a technical point of view. Obviously, for you to be able to use that data, it still needs to be approved by the DAC, right? But again, many of the risks that will be intrinsic to, for example, analysis of genetic data will suddenly disappear because you do not have physical access to the data. You cannot take that data with you and somehow later re-identify it, because you, as the user, the researcher, the developer, you do not actually see the data yourself. The data is being used by the algorithm, but you don't see it yourself. So there are some technical mechanisms that can make some of the questions of which data is being used and how can you make sure that that's safe There are technical protections in place, but that's just one of the many pillars that we need to focus on. And obviously everything else around governance and ethics and making sure that when we do engage with our patients, with our PPI groups, that we are engaging with them seriously and really trying to get proper engagement and get them to appreciate the complexities of everything that we're doing. All of those pillars, when they come together, they should give us the confidence that we are doing something that will be of value with the risk in a way that has been as minimal as possible.
Nicola, is there anything you wanted to follow on with that?
Yeah, I think that's really interesting. And to that, I think here it's helpful to think about Caldecott Principle 8, which is essentially that there should be no surprises for people in how their data is being used. And I think that raises questions, and this is some work that myself and my team, my panel want to look at over the next year and do some research on this. How do you create reasonable expectations for people with new and novel ways of using data? And Robin mentioned an algorithm running over his notes. If I go to a health service because I've got a broken leg, I think there is an argument. It's stretching the concept of implied consent as a legal basis to say that I'd expect an algorithm to be just run over to determine my risk of dementia or certain cancers, for example. So I think there are all sorts of questions that we need to come back to. Are we using data in a way that people would expect? Would they be surprised to know what we're doing? And if that's the case, what are we doing to engage them and make sure that our use of data remains within what people's expectations are?
And I think that point that you're making is incredibly important now in the new age of AI, because obviously these machine learning algorithms, they learn relationships in data that might often be very complex to explain. So there might be a relationship between the fact that you broke your wrists and maybe the fact that 3 years later on, you're at an increased risk of having some other pathology. There might be relationships there which are hard to explain. So obviously to convey that an algorithm is using a piece of information maybe from a couple of years back to predict a disease which seems to be unrelated a few years in the future, sounds a bit far-fetched from the point of view of patients. But the reality is there is information in that data, right? And often we would like to be able to maximize the amount of information we have available to us so that the predictions and the diagnosis and our ability to care for patients is as good as possible. But it is indeed true that there's this big gap of human understanding of what AI algorithms are actually doing and what information they're utilizing. And how do we explain that that information can almost come from everywhere and not necessarily only from the pieces of data that you would expect?
Yeah. And I think there's also, this is the last thing I'll move on to another question. It's such an interesting one. I think there are also think about different use cases, what the expectation of human agency would be in that. So, you know, if I'm told that an AI tool has determined that I've got pre-diabetes, I'll think, yeah, fair enough. What do I have to do about that? But I might have very different, and that I'd be quite happy to be a passive recipient of that information, if you like. But I might have very different views if I know that an AI tool is perhaps determining my place or triaging my place in a waiting list, or my suitability for treatments that may be limited as a resource. Someone else might be deemed to be more suitable for that, for example. So I think those are very different expectations that people might have about those questions of human agency, what might be contended or what might just be a simple, straightforward, if you like, determination that's quite useful. And you know, decisions that are more easily expressed in computational terms like imaging, that seems quite straightforward. But then I think when we get to all the potential uses, more the art of medicine side, things feel much more complicated and we need to do more thinking.
Thanks. Robin, over to you.
Just a really small add-on comment that morality isn't absolute. So our context defines what we think is good and bad, which makes these questions even more difficult because what the public might think is good now might not think it's good in 5 years' time. So something that really brought this home to me was the whole everything that's happened in America with abortion. So if you were in England, you might not potentially have as much of an issue about an AI working out with your clinician that you are pregnant before you know that. But in an American context in certain states, you might have a much bigger issue with that. And we don't know what our situation will be until hopefully we're in a good situation in 10 years' time. But we don't know what the situation will be, which then will change what we think is good and bad and what we find acceptable. So it is a continuing, ongoing conversation. And I find the psychological definition of trust really interesting, because it basically says the act of trusting someone is the choice to be vulnerable with them because you're expecting like good choices from them. And I think it's about being able to continually show that you will make good choices in that changing context that's really difficult, but also absolutely paramount.
Yes, really interesting to think about the different contexts in that, with regards to that. George, over to you.
The only thing that I wanted to add is we already have the concept of evidence-based medicine, and that's pretty much the standard nowadays in how do we care for patients. And a lot of evidence-based medicine results in relatively simplistic, but still algorithms. So decisions that are made at the population level and then applied to a single subject. And those algorithms, we currently deem those to be reasonable because the studies have been shown to be large, well calibrated, and done properly. And because of that, we can apply them at a single subject level. But it should always be ultimately the clinician making the decision as to when that algorithm should be applied or not. So for me, the way that I like to think about AI is kind of a evidence-based medicine 2.0, which to the extreme, right, is a way that you can take evidence and make the best you can out of that evidence. Doesn't mean that the clinician will need to follow this recommendation of the algorithm, but it's just the extreme case of evidence-based medicine. Is rather than having a decision tree with 3 levels, you have an incredibly complex decision tree with many, many, many millions of variables. So that evidence-based medicine 2.0 view should give us a good underpinning and understanding of what automated decision-making is, because it's nothing more than following an algorithm, for example, like you would have in standard evidence-based medicine setups, but it's more about how do we now change the complexity of the algorithm and how do we accept when to apply and when not to apply those algorithms, depending on situations that we have in front of us.
Fantastic, really insightful. Just conscious of time, so we've got a couple, probably time for 1 or 2 more questions before we start wrapping up. But I just want to say, if you've got any questions and you want to put them in the chat, if we haven't had a chance to answer them, I'll be a bit cheeky and ask if we'll follow up with some emails, and I'll see our panel them later. Last question that's just put into the chat from Gabby, just as I see that. About social contract, while this is a federated system might ensure data doesn't have the data lake in a hospital, the value attached to this data is transferred to the algorithms, which are more porous and fluid. This political context in which algorithms live raises questions associated with the issues of trust, for example, public-private partnerships, benefit sharing. Is this something that you thought about in your impact assessments? Very broad question, very deep question for our last one of the session.
Robin, do you want to come in?
Yeah, I'm trying to work out what the actual question is in it, and I don't know if this is me being stupid. If someone could simplify the question for me.
And maybe I can just put some thoughts through. Every time we collect evidence and we distill evidence into decisions or any process or any decision, right, we are going to have an impact in people's lives. And obviously the value is in how do you keep those decisions and how those decisions can interact with the rest of the healthcare system to maximize value to patients, which normally means maximizing outcomes and minimizing costs at the level of the NHS. Obviously, the data itself is valuable and we're not letting the data leave, which I think from a privacy point of view is good. But it does also mean that, as is said here in the question, the value of the data goes into the algorithm. What we had to learn from the data is now part of the algorithm. So somehow we've transferred that value to the algorithm. As part of the AI Center, we do work with startups and we do work with large multinational companies. And in situations, they can use our platforms to train their models on patient data. And there is the components of the contract that exists between the AI Center and companies, which is signed individually by each one of the trusts that participates in that specific project, where there is a revenue sharing, for example, and there's multiple models. We shouldn't really be discussing exactly the different financial models, but there's multiple ways that revenue can be brought back to the trusts themselves. But also, and I think that's incredibly important, is because the data is never being given to a company, If the company wants to update their algorithm, let's say 2 years in the future, they need to come back and work with us again. What that means is that company needs to maintain a long-term relationship with the AI center, with the hospitals, with the universities, rather than just trying to convince us to give them the data the first time, right? And that long relationship means it changes completely the perspectives and how they're approached. It means that they're not there to convince you for us to give them a bunch of data and then they can run away and do whatever they want with it, right? They are there to work with us for the foreseeable future, right? And so that changes very much the value proposition. It means that this interaction is much longer term, but also it means that we're capturing the value of that data throughout this journey, including the fact that we're working with these companies. We're bringing economic prosperity to the UK by bringing developers to the UK and developing these technologies here. So there's many components of value that I think we need to capture in how we run these research setups.
Fantastic. Thanks so much, George. Very conscious of time. Any final comments from the lovely panel? Nicola, is there anything you wanted to add?
Yeah, I just wanted to use that question as a platform to making a cheeky plug for work we're doing and our website. Our annual report just been published, looking at public benefit, including those very thorny issues of commercial interests. It's something we've been doing a lot on in the last year, and we're going to be producing some guidance. So if I can, I'll put it in the chat. But if you search for National Data Guardian gov.uk site, you'll see our report and work we want to do around people's expectations and public benefit, which I think very much relates to that last question.
Fantastic. Thanks so much, Nicola. Harris, any last words?
Yeah, I mean, the question's an interesting one, and maybe we can think about parallels are networks, like the internet or social networks, where the thing is valuable because everybody participates in it. Maybe there's something we can learn from there. But more generally, and again, to follow on from Nicola, a plug, I think we can, the benefit of these platforms, both Flip and Aid, is that we finally have something on the table around which we can talk about, where we can implement policies and test them in the real world. And so this is a bit of a call out to everybody in the audience, whether you're an innovator, a patient, a clinician, if what you've heard and seen about Flip and Aid is interesting to you in your work, we have a very large tent and we can expand it to include more. And we want to hear about how the platforms can work with what you're trying to achieve and how we can solve some of these questions under that rubric. That would be my final thought.
Brilliant. Thanks so much. Robin, have you got 30 seconds before I have to finally wrap up? So come on.
30 seconds. Okay, cool. So just on the social contract question, I think that was talking about the trade-off of value, and just to say that there are 5 government principles, and one of those principles is the fair, giving fair value back to the NHS when NHS goes out. That's something that obviously not just an ethical basis, but on a government basis that we will follow. And the final thing I wanted to say was that we've spoken a lot about how we should do things, but we haven't spoken a lot about the why. And I just want to kind of finish on the point that the reason we're doing this is not because AI is cool or not because publishing research papers is great, but it's because there are sick patients that need help and want better quality of care. And that's the whole point of this. So I didn't want that to get lost. Done.
Yeah, brilliant. Thank you so much, Robin. My lovely assistant is going to be putting up a quick feedback, so a quick feedback poll. So please take 30 seconds to answer that, basically asking how useful was this session. As I mentioned at the beginning, this is the first in a series of webinars, so I'd really encourage you to sign up to the next 2. So the next one, which is actually on the 2nd of November, The Doctor Won't See You Now, Machine Learning for Examples that You Never See. And the final webinar will actually be in December, looking at the NHS in the driving seat, building a clinically led AI ecosystem. So hopefully you found this helpful. Do sign up to the next webinars, and I just want to thank the lovely panel for taking your time today. And thanks to the audience for such great questions. Hope you all have a lovely afternoon.